time is where you're at. It's 4 minutes gone past the hour of 1. I am the host of this show, Surviving Sickle Cell, a show in partnership with the Sickle Cell Foundation of Nigeria. Yes, and we have our national director, Dr. Annette Akinsete, in the house. How are you,
Fine,
ma'am?
thank you. Very fine, thank you.
All right.
How are you, Thelma? Welcome back.
Thank you. And of course, we have a gynecologist. He's Dr. Chris Makwe, a consultant obstetrician and gynecologist from the Lagos University Teaching Hospital, LUTH, Lagos. You're welcome to the show, sir.
Thank you for having me here.
All right.
And the lecturer as well, lecturer in the
College of Medicine.
University of Lagos.
Also,
So he wears two caps.
he looks like one.
The teacher.
I would just, keep silent in that regard. So today, most interestingly, we're talking about something interesting as regards the sickle cell disorder, and we're talking about sickle cell disorder in pregnancy. Like that is so super duper important. So, Dr. Makwe, I would have just really gone first by saying, can persons with a sickle cell disorder, can they actually get pregnant? But that's an absolute yes, because that's why we have kids everywhere. That's why we have people with a disorder, because there has been a mama and a papa who came together and then who birthed these people. So probably what I'll be asking you first is, should women or persons with a sickle cell disorder be encouraged to have babies?
Definitely yes. They have the right to reproductive health. They have the right to have children. But what is important that they should also understand the risk involved in having a pregnancy with a sickle cell disorder, because just put it, they are more likely to die during pregnancy than the average patient that doesn't have a sickle cell disorder.
Okay, so hence the topic of this show.
Very important.
So, what steps, measures, or actions, should be considered when embarking on this journey?
I think what is important that I think patients and people in general should know is one, the possible complication associated with pregnancy in people with sickle cell disorders. But what is important is more of information. People, before they even think of getting pregnant, should come to us, and they could have what we call pre-conception care, where we'll try to assess their risk of developing complication during the pregnancy. And for those risk factors that we could modify before they get pregnant, we could actually do some amelioration or even correct those risk factors before they embark on the journey. And when they now get pregnant, what is important, they also present to an obstetrician gynecologist who is experienced in managing patients who are pregnant with sickle cell disorder. And patients are actually encouraged to register or book for antenatal care early. And the truth about it is that because of the concern, we tend to pay more attention to this group of women. So in terms of the frequency of antenatal visit is more, the attention to details is more, and for any deviation from the normal, some of these patients are further evaluated, either to detect complications that are starting, and when you detect them early, you're able to prevent or treat it before it results to something more harmful or detrimental to the mother and the baby.
Okay.
Yeah.
So you did say really, because for most of us who do not have the disorder or the trait, we tend to go for the antenatal care from 4 months, 5 months. I know of someone who didn't go until 7 months, and then
Some don't go at all.
Yeah, some don't go at all. Thank you. So how early really is early for one with a sickle cell disorder to begin to attend antenatal care?
For us, we encourage them to register in the first trimester, the first 13 weeks. For me, I would tell them as soon as they miss their period, they come to us to confirm the pregnancy, the number of pregnancy. And for some of them who have missed that opportunity to have pre-conception care, that's also another time to assess them. Okay, and it's also good to assess these patients when they are healthy before they develop crisis, because you now have a baseline information about them when they are much healthier compared to when they present in emergency situation with complications, in which case sometimes we don't have records of what's maybe their blood level was before pregnancy and certain other parameters. So it's always important they register early. Okay, and we'll take it from there.
Okay, you said something about preconception care. What's that about?
This is things we do for people ideally when couples get married. They should plan when they want to have children, the number of children they want to have, and they can come to the gynecologist, and we have like an evaluation. And for the sickle cell, people with sickle cell disorder, this is very important. You want to know what is what we call the steady state hemoglobin level or packed cell volume. You also want to assess the frequency of their crisis, because you don't want to encourage them to get pregnant if they have just been fallen ill with a lot of crisis, because it's definitely going to worsen during pregnancy. So you also want to do some blood tests to assess their liver function, the other organs, make sure they don't have any long-term effect of sickle cell disorders. Some of them at the time they are presenting might have what we call sickle cell nephropathy. This is a kidney disorder that's pre-existing even before they get pregnant, and we can advise them about what to do and how to manage their pregnancy. It's also an opportunity for us to give them some preconception medication, like as simple as folic acid, which is a multivitamin, can help a lot. Some of them already on folic acid, some of them are not. You have to tell them the importance. And it's also a time for you to inform them about the possible complication that can happen during pregnancy. And sometimes, yes, they have gone through this from childhood. They think they understand the process very well, but in pregnancy it can take
it's a different ball
it's
game.
a different ball game, and it's the rate at which the complication can progress to more severe life-threatening condition is very, very fast, and they need to understand that. And this is also an opportunity for us to tell them when they are pregnant, they make sure they keep themselves hydrated. And one of the things we tend to encourage them to do is that wherever they are going when they are pregnant, they should have a bottle of water with them. Always, so they keep themselves hydrated, especially in this environment where, because of the temperature, things they can get dehydrated easily. Avoid stressful exercises and activities, that will also help. And also the extreme weather, like also avoiding places that are too cold. These are things that can precipitate a crisis. And once there's pregnancy, some of these things accelerate very, very fast. So that's an opportunity for us to do all that during the preconception care. So these patients are better informed going into pregnancy, and they know what to look out for and what to report to the obstetrician.
So we seem to have preferred solutions already without even talking about these complications, because I think the complications like the cocoa, the one that really the things that these women actually go through when you're pregnant. But before you mention that, as a doctor, from your experience, would you say before a validation to say as a doctor to a couple that yes, you've gone through a series of tests, and you're given the validation and say yes, you can actually get pregnant, this is what is supposed to be done, would you say it varies from persons to persons or couples to couples? Just like you said sometimes they come, they probably have some sort of kidney issues or things like that, and then it's probably the recommendation is probably a no or something. Are there cases like that?
Well, sometimes you can have the extremes where you have people who have a lot of risk factors. They have hypertension, they have kidney problem, and you look at all of that. But what is important is for you to look at the risk factors and see the ones you can control, prevent, or ameliorate. But
so
sometimes
those are the high risk factors.
So
is
so
it
you
a no for them, or is there a solution?
sometimes they might have a little group of patients where you say no, but most times you just let them know the risk, because you're not the one to decide for them. Sometimes we work in conjunction with other multidisciplinary team, like the nephrologist. I've had a situation where the nephrologist said, look, please do a preconception evaluation for this patient, because I don't think it's safe for her to get pregnant, and she's really, really eager to get pregnant. And they come to me, and but basically we don't dictate to couple, but we tell them the risk involved, and if they decide to go ahead, what's
their choice?
Choice, and what they should expect. And sometimes for some of those risk factors, if they're with the people who are experienced in managing this condition, yes, there are a lot of challenges, but some of them can actually still achieve pregnancy and give birth with the risk factor being present.
All right. 14 minutes gone past the hour of 192.3 Inspiration FM is what you're listening to. You're actually listening to Surviving Sickle Cell with Thelma Illens, Dr. Annette Akinsete, the National Director of the Sickle Cell Foundation Nigeria. And yes, and that's the foundation actually that Inspiration FM is partnering with on the show, and we have Dr. Chris Makwe, consultant obstetrician and gynecologist from the Lagos University Teaching Hospital, LUTH, Lagos. Sickle cell disorder in pregnancy, a very, very interesting, very important topic is what we've been talking about in the last 14 to 15 minutes. If you do have some concerns, fears, questions, something that takes you to a land of wonderland, you can actually call us, get through to us via our number 0700 923 923 923, or simply send a message via WhatsApp platform. The number is 0817 313 6193. All right, Dr. Makwe, can we look at some of these complications that come with pregnancy for women who have the sickle cell disorder?
All right, so the one that comes to mind easily is the crisis that this patient with sickle cell have. There are different types. We talk about the vaso-occlusive crisis when they come with bone pains and severe pain. In pregnancy, the frequency of that occurrence is increased, especially during the till end of the pregnancy, the last 4 weeks, and immediately after delivery, especially the first 4 days, they can have this. They can also have hemolytic crisis when their level of hemoglobin or blood level drops suddenly, and it could be very fast in pregnancy, and life-threatening actually, and sometimes requires multiple transfusion to get them to safe level. And because they basically have a baseline lower level of their blood level, what we call hemoglobin, this tends to affect their baby in utero, so they have less oxygenation and blood supply, and this can make the babies not to grow optimally, and they have what we call intrauterine growth restriction, where the baby for their age in utero are much smaller than expected.
Okay, just hold your thought on the complications. Let's see who's out there. Hello? Okay, do try to call us back. The number again is 0700 923 923 923. Yes, you were talking about growth.
Yes, so the babies are not growing very well. For some of them, if they are not picked early, these babies can stop growing, and if you still fail to pick that, you just come one day and the baby is dead, and so they tend to have a higher.
That's in the womb?
Yes, so they tend to have a higher rate of stillbirths, people with sickle cell disorder. So this is one of the complications. In terms of infection, because they're also prone to infection. Already in pregnancy, there are certain infections that are common, things like urinary tract infection, but this is more in patients with sickle cell disorder, and sometimes they even have some infection that they might not even know they have. Like a urinary tract infection, what we call asymptomatic bacteriuria. So they have bacteria growing in their bladder, and this can cause more severe infection in the kidneys. So this can lead to what we call an acute pyelonephritis.
So can these be detected during antenatal phase?
Yes, these are things we do. So from the first day they come for antenatal care, during their booking, we take their urine, test for things that will suggest infection, and sometimes go ahead to culture the urine for this organism, and where we identify the causative bacteria, we could give antimicrobial agent to clear the infection, so it doesn't lead to any severe complication that can be life-threatening either to the mother or the baby. So these are things we could do. And in terms of picking up the babies who are not growing well, apart from the regular antenatal visit where we examine these women and check their baby clinically, we could also monitor them serially with ultrasonography, where we do scan at intervals from the 20th to 24 weeks. We do the regular, so that the scan can now measure the growth of the baby, and where we suspect the baby is not growing well or there's harm coming to the baby, we can plan delivery even much earlier. So those women with sickle cell disorder are more prone to having preterm delivery, that's delivery before the babies are term or matured, and so sometimes the baby comes smaller, premature, and they have to be in incubator for some time before they are allowed to join the mother. So these are all possible complications that can happen. And sometimes even when they do very well and they come in labor, there's still a challenge, in labor too, when some of them, because the babies have what we call poor reserve during the contractions of labor and decreased blood supply to the placenta, the babies can show signs of fetal distress, and if you fail to pick this fetal distress, you can still have a stillbirth in labor, or you can lose the baby, or sometimes the baby comes out there, they have issues or difficulty with crying because they have what we call batasphasia, and sometimes this can lead to very severe complication in the baby. We'll talk about cerebral palsy or things like that. This can result from poorly managed labor in women with sickle cell disorders. Yes.
Can I ask a question that many of our clients in genetic counseling ask? that would they always be subjected to cesarean section?
No, there should always be an indication for cesarean section, but the truth is that for a patient with sickle cell disorder, you have a higher chance of having a cesarean section for a lot of reasons that are well documented. Apart from, like, if the baby is not growing very well and you're not in labor, this might just prompt the doctors to say, look, the best mode of delivery would be a cesarean section. Sometimes they can come in labor and there's a fetal distress in labor, and the only way to expedite and deliver the baby before harm comes to the baby is to do a cesarean. So they have a higher chance of having a cesarean, but you do have patients who deliver vaginally, and we tend to opt for vaginal delivery because that's less complication. Because when you have cesarean section, there also increased risk of infection after the cesarean section. They can have what we call deep venous thrombosis, where they have clots in their lower limb that can go to their lungs and cause more complications. So where there is no contraindication, we opt for a vaginal delivery. But when there is, then we'll opt for a cesarean section. Sometimes it's just because we have some patients, they're not yet due, but they're having so much crisis late in pregnancy. Some of them, they have been on admission, they're in painful crisis for 2-3 weeks continuously, no matter what you do. And when you assess that the baby is getting closer to delivery and it's safe for the baby to be delivered, and the woman is not in labor, and you don't think there's need for you to start or induce labor, you could just proceed with a cesarean section. And sometimes once they deliver, they tend to reverse back to what their pre-pregnancy condition usually is. So they tend to have lesser crisis. So we know most of the things are exaggerated because of the pregnancy. So as soon as the pregnancy stops, they tend to go back and they do well. Sometimes you have patients who all through their life, they don't even know what is a crisis. And the first time they're experiencing a crisis is in pregnancy. And that's sometimes strange to them. They look, I've been fine. Especially when we see patients who have hemoglobin SC. They live like a normal life. I've seen some of them say, when was the last time you had crisis? I don't know what's crisis. I've never had a crisis. And now in pregnancy, the thing that is bringing her to the hospital is just severe bone pain crisis. She's having a vasoocclusive crisis. Sometimes they don't understand what has been happening because they've never had it before. Some people are used to it because they've had it in the past, so they can tell you, some of them can even have an aura. They tell you, I think I'm going to have a crisis. It's coming. So they can tell you. So they can even come to the hospital earlier. And these are things we tell them. When you think something is not going fine, present to us so we can start treating it before it generates to something very, very bad.
There are some patients who are SC who do not know at all they have sickle cell disorder until pregnancy. Because of what he just said, they've come to us as well. There's also a preventive medicine aspect that I think we should bring out here. That even Dr. Makwe has spoken to the fact that there's the pre-conception care. But in preventive medicine, we actually say that all girl children, a girl child, should always, the parents and healthcare team should always bear it in mind that this child aspires to be a mother sometime in the future. So every aspect of her care should always bear that and be mindful of that. So in teenage years, in school, so school health programs and together with all the entire health team should always care for this girl child, bearing in mind that this child may be a mother, and because our goal of treating them usually is that they aspire to be mothers, they aspire to live normal, healthy lives. So we don't preclude them from getting pregnant, and we begin to care for them long before. So all the genetic counseling and everything that's done to take care of them speaks to looking at this child as a potential mother sometime down the line.
All right, well said. 7 minutes before we step aside on surviving sickle cell. It's been most insightful, really. So much light thrown. And I was just going to ask Dr. Akinsete, you needed to say something on this. And yes, she's actually throwing that light. But we're going to take a break now. When we come back from that break, Dr. Makwe will be telling us, is there an actual way to prevent my baby, if I have a sickle cell disorder, from also having the disorder? Is there a way to determine that, yes, this baby, I don't want this baby to come out as a sickle cell disorder baby? I know we've heard something like that before from Dr. Akija, yes, but I would really just love for you to throw more light. We'll take a break. 92.3 Inspiration FM, Surviving Sickle Cell, brought to you in partnership with the Sickle Cell Foundation Nigeria. Don't go away. Just talking about that caller who just keeps calling at should I say suppose at the wrong time. So yes, you were actually calling during the break. We couldn't be taking that call then, but let's see. We have less than 4 minutes to get out of the studio. So if you can actually get through to us quickly with that question of yours, because I feel like it's really, really important. The number is 0700 923 923 923. But if for some reason you really can't get through to us via our phone line, you can actually get through to us on our WhatsApp platform. Okay, the number is 0817 313 6193, and perhaps I can just put the question through to the doctors in the house. Sickle cell in pregnancy is what we've been talking about with Dr. Annette Akinsete and our gynecologist, Dr. Chris Makwe. Is that your first name, Chris? Okay, great. So before we went on the break, I did ask if there's an actual way to actually prevent your baby from having the sickle cell disorders. Is that something one can actually do? Is there a marker somewhere?
Yeah, there are options, and this the community and will I say the society is also addressing, because you see some people even before they get married, people are going for genetic testing. That's a way to know their genotype and also prevent having children who have the disorder. But sometimes by the time they are coming to see us, they're already pregnant, so we can't change whatever is there. The genetic imprints start from conception, is already there. But sometimes we have requests where people who probably they are ASAS and they want to know if the baby they are carrying in utero is possibly SS, and we have ways of testing that. We could do what we call chorionic villi sampling or amniocentesis to get
sample. At our center,
and they do it at the Sickle Cell Foundation here in Lagos. And you take the sample and you analyze it, and you could tell the genotype of the baby before it's born. That's we could do. The other option we have as gynecologists is where we do assisted conception. We have the ability to select the embryos that don't have sickle cell disorder for embryo transfer into the womb of the woman. And if you implant and she gets pregnant, we're certain because we tested that embryo before we even transferred it into the uterus.
It's implanted, right?
Yeah.
Is that pre-implantation genetic
diagnosis? Yes,
diagnosis?
that's called pre-implantation genetic diagnosis. Yes, and you only do it when you're going for assisted conception, like IVF, in vitro fertilization. Yes, so that's technologies available in Nigeria.
So in the end, it's all about the information. It's all about being sensitized from the very beginning.
But ethical considerations, mind you, for all these options.
Okay, ethical considerations.
Yes, and religious, because of connotations as well.
Okay.
So we're dealing with embryos outside of the body. You probably have to discard a number of embryos, and then churches will tell you that you're committing murder.
Okay, so finally, I think he got through, or she got through. Hello, good afternoon. Are you there? Fantastic. Tell us your name, please, and where you're calling us from. Okay, Jane, where are you calling us from? Are you on the road? To say our goodbyes, but before we go, Dr. Makwe, is there honestly anything you'd like to chip in before we
One last word.
Well, I think for people with sickle cell disorder or traits, they should always consult their physician when they think about getting pregnant, and when they actually get pregnant, they should follow up early with their obstetrician. That will prevent a lot of this concern and complications associated with sickle cell disorder in pregnancy.
Okay.
But on a note of at least giving people hope that persons with sickle cell can have children, okay, and they aspire to do so, but they should do so in a healthy and caring environment, and seeing the doctors regularly with a team, because it's a team effort. It's not just your physician, your obstetrician, gynecologist, and early on, even before pregnancy.
So on that note, I would say that knowledge is not just power, knowledge is living. We gotta go. This show has been brought to you in partnership with the Sickle Cell Foundation Nigeria, of which Dr. Annette Akinsete is the national director. We've had gynecologist who specializes in pregnant or women with sickle cell disorder who get pregnant, and you can tell already he's an expert. He's Dr. Chris Makwe. So Jane, I'm just giving you his name in case you get there. You can try to find out. Okay, and not to forget, this show has been brought to you in honor of our beloved Tracy Buckner, okay, who passed on November 19 in 2018. And we say, rest in peace. My name is Velma. I'll be back on Monday at 11 for the tea break. Have yourself a wonderful weekend. I'll leave you with this one, Whitney Houston's